So in today's video, we're going to be looking at muscular dystrophy, specifically Duchenne and Becker. So there's 4 criteria that is required for diagnosing a dystrophy. The first one is going to be, it has to be a primary myopathy. Secondly, it has to be some type of genetic basis, so it can't be infectious or any other basis. Third, it has to be progressive, so it can't stay still. And finally, there has to be some degeneration or death of the muscle. So these are the 4 criteria required to generally tell you that you have a dystrophy, and then there's going to be, depending on which dystrophy you have, there's going to be some things that are which more specific. So next we'll move on to is going to be pathophysiology. So first of all, Duchenne muscular dystrophy is the most common hereditary neuromuscular disease out there. So it kind of has that role to play. Not Becker as much. Becker is going to be a little bit less prominent. It is X-linked recessive. It's linked to the XP21 gene, which codes for the dystrophin gene. And so what does the dystrophin gene do? First of all, it is one of the largest genes in the entire DNA, and this is why gene therapy is a little bit difficult. What it does is it connects the connective tissue to the muscle. So in other words, it transfers the energy from the muscle to the connective tissue. So it's very, very important in your muscle movement. Even though it's X-linked recessive, 30% are actually new mutations. So very common to get new mutations in asymptomatic mothers. Girls do get this. It is a milder form, and this is kind of follows the Lion hypothesis, which says that since women have the bar bodies, they tend to only 50% of their cells will have the troubled cells, and the other 50% will be okay. So it tends to be slightly milder. And because of that bar body theory, it tends to be high in patients with Turner syndrome, which is 1XO. And also there are asymptomatic female carriers, and the only symptom or finding that you'll have is an increase in creatine kinase in about 80% of them. So now this pathophysiology is the same for whether you're talking about Duchenne or whether you're talking about Becker. The only thing is, in Becker, it's going to be much, much milder. Okay, so after talking about pathophysiology, let's go over to the clinical aspects. In the first year, everything will be pretty much normal. So they'll have their normal or maybe slightly delayed milestones, but it's very slight, nothing to be kind of too much worried about. You will have normal walking at about 12 months. However, there may be some hip girdle weakness. So even though they're normally walking, they might have some slight hip girdle weakness that might give you some point. One of the first signs, however, is that they have poor head control early on. But again, that's very, very slight sign, not diagnostic by any means. Then as they become toddlers, they tend to walk okay. They tend to be slightly lordotic. And this is because they're trying to compensate for gluteal weakness, because one of the first muscles affected is within the hip area, specifically the gluteus. Now, in 3 to 5 years, this is when you start actually noticing the Gower sign. And so this is a very, very prominent sign, and it makes the disease very apparent that this patient is suffering from something. So generally what happens is that when they try to get up, they move their hands onto their knees, and then they try to walk up as they're moving. So and then this will and so when they're trying to walk up as they're moving, the reason they're doing this is because the area of the hip and the gluteus is weak, and so they have to use their distal muscles to get up. Now, by the time they become 7 to 8 years old, they become wheelchair bound, and they can extend this to 12 years old if they get treatment early on. And the treatment that they generally receive is going to be more like physiotherapy and strengthening the muscles. Now, by the time they're 20s, you have a lot more going on. Since the distal muscles are preserved, they are able to do things such as eat, write, and use a keyboard. However, after a while, they tend to develop respiratory symptoms, and this is characterized by a weak cough, increase in infections, and having a decreased respiratory reserve. Finally, you can also get pharyngeal aspects in their 20s, and in this they'll have increased aspiration, there'll be liquid regurgitation, and they'll tend to have, and their voice quality will be much more nasal. Beyond this, there are some other complications that can occur. Firstly, they can get contractures, and these contractures will occur in the ankles, knees. You can also get them in the hips and the elbows. Besides this, it is associated with scoliosis, and this scoliosis occurs early on, but once they become ambulatory, it increases with ambulation, so once they get in that wheelchair. Next, the most characteristic feature is going to be pseudo-hypertrophy, and this is when you have enlargement of the calf muscle. So the calf muscle becomes much enlarged, but this isn't due to, because it's stronger. What it's due to is hypertrophy of the actual fibers. And then what happens is once it hypertrophies, you have fat infiltration, and then you have collagen deposition immediately afterwards. There also is some thigh atrophy, and that's just because of disuse atrophy. And of course, pseudo-hypertrophy can also occur in the tongue as well as the calf. Next is going to be the cardiomyopathy. That does occur, so it's a smooth muscle. What tends to happen is they become tachycardic, and they eventually go into congestive heart failure. Interestingly, it's not usually correlated with the skeletal muscle, so they might have a severe skeletal muscle disease but very minor heart disease, or they might not have much skeletal muscle disease but have very severe heart disease. So they're not generally correlated with each other. Next effect is going to be on the intellect. These patients are associated with a very low IQ, sometimes less than 70 and about 20-30%. However, sometimes it's much more subtle and they just need some type of remedial help in school. Overall, they're okay. And finally, there is a slight increase in epilepsy. And this all is because dystrophin has been found in the brain. So they feel like this is the reason why they tend to have all these intellectual problems. And finally, and quite sadly, death usually occurs due to respiratory failure in sleep. In Duchenne's, it's going to be mid-20s. Mid-20s is Duchenne's. And in Becker's, it's going to be the late 20s. So Becker's, again, it's a little bit more milder, so it tends to be a little late. And between Duchenne and Becker's, that's the highlighting feature. Becker tends to be a little bit less severe, slower onset, and Duchenne tends to be more severe, quicker onset, and death occurs a few years earlier. So what type of investigations would you want to run? The first investigation that you generally want to do is the creatine kinase. This is high early on as they have muscle, but as they begin to lose muscle, then it becomes decreased in the late stages. You also want to do an echo, ECG, and an X-ray of the heart to look at the heart changes and what's going on. You can also do electromyography. This will usually show everything normal because there's no denervation, and the motor and sensory neuroconduction is going to be normal. So how do you diagnose it? Definitive diagnosis. One is you can do PCR of the dystrophin gene. So this is a pretty classical way of diagnosing it. However, if you get a negative, you might want to also do a muscle biopsy, and this is because this can catch up to the 1/3 of the false negatives. So this is very important to do that. The test that you do is called dystrophin immunocytochemistry. So that's the test for it. And generally the biopsy that you would take is either going to be from the quadriceps or the gastrocnemius, which is the calf muscle. Treatment. We can talk about treatment now. So the treatment, there you go. Treatment is, there is no cure, and there's no way to really slow it down, which is, sad fact. But you do try to limit the complications, and you try to increase the quality of life. So the first thing that you want to do is, you want to protect the heart. The heart, you can use the digoxin, that tends to work pretty well. Next, pulmonary infections. First of all, there's a few ways you want to tackle this. The first thing you want to do is you want to avoid people who are sick. You want to keep these patients vaccinated, and if they do get an infection, you want to make sure that you treat promptly. You treat it right away and treat it very aggressively before it gets severe. Next thing that they can also do is they can do physiotherapy. Physiotherapy is oftentimes done for the contractures, but sometimes the contractures can be beneficial. And this is because oftentimes, like with regards to the elbow, if it wasn't contracted, it would just flail around everywhere. So the contraction will keep it in 90 degrees. It'll kind of keep it up, and then they can actually use their distal muscles. So you might actually want to leave the contractures where they are. Next, exercise. You don't want to do. You want to do exercise, but not too rigorously. Otherwise, the muscles can't handle it, and you get increased degeneration. Finally, glucocorticoids. They have been shown to decrease the rate of apoptosis and increase strength, at least initially. It does tend to stop working after a while. And the problem with this is there does tend to be apoptosis and weight gain that generally occurs with chronic use. And so you get these, I guess, Cushingoid symptoms that you need to watch out for. So this is the muscular dystrophies. Hope you enjoyed. See you in the next video. Thanks.